In this section, Module 5, we will have more in-depth study of language development and where that breakdown occurs. We'll talk about the populations that are affected by language disorders and evaluation and treatment of those language disorders. We will mainly discuss disorders in children, but we will discuss language disorders in adults in subsequent chapters and modules. As previously discussed, language is divided into 3 areas: form, content, and use. Thus, language disorders or language impairments are going to be categorized by these 3 areas. If a child has a breakdown in language, it's going to happen in form, content, or use, or in all of the areas. Remember, form affects phonology, syntax, and morphology. Content is semantics or meaning, vocabulary, and use is pragmatics and social skills. Let's take a look at the breakdown that might occur in each of these areas. Let's first talk about form. You will remember that phonology is a part of the form of language. And phonology is the study of phonemes. And phonemes are those sounds that make up words. So phonological awareness is the ability to think about and manipulate sounds and syllables. So if a child has a problem with phonological awareness, they may have a problem with sound awareness, being able to manipulate those sounds and taking maybe the g sound and putting it at the end of a word. Or they may mistake the g sound for the b sound or the k sound. So they may not understand that those sounds have different meanings and make up different words. Also, syllable segmentation and word manipulation may be a problem a child might have. So they may not understand that certain syllables make up words, or they may not understand that they can combine words to make a compound word. Research has shown us that phonological awareness is linked to reading and writing skills. So if children have this impaired phonological system, they may have an impaired literacy system or impaired reading, writing system. You remember when we studied speech sound disorders that some phonological processes are typically developing. So some children may just swap sounds or mispronounce sounds because of a developmental stage. However, if these persist past 3 or 4, then we know that there might be a bigger problem. And some phonological processes are idiosyncratic and are not developmental. So we need to be aware of what is typical and what is not. Another system within form is morphology. Morphology makes up grammar of language. It's one component of grammar. Morphology is the study of morphemes, and remember, morphemes are the smallest unit of language that express meaning. That table on page 83 that we talked about in Module 4 shows the 14 morphemes that children should develop. When a child has a delayed morphological system, it affects their grammar of language. So they may be leaving off plurals or past tense. They may not know when to add ing or use prepositions or articles. This is all part of morphology. The last part of form is syntax. Once again, syntax is a part of grammar. So syntax and morphology make up grammar. And syntax, remember, is word order. So it's the ability to put nouns and verbs, adjectives, adverbs together. This system, same as the morphological system, expands with age. So as children get older, their grammatical system becomes more complex. This rule system for developing sentences can be broken down at any area. So, for example, can children make statements and questions? Are they able to use negation? Do they use complex sentences and passives? We also look at, are they using clauses and phrases instead of full sentences? Let's talk about content now. If you remember, semantics is the one area of language that is in content. Semantics is the meaning or vocabulary of someone's language. It's the system of language. It's the ability to know multiple meaning words. So, for example, does bark just mean the bark on a tree, or does it also mean that action word of a dog barking? As children get older, semantics involves similes, idioms, humor. So do children understand figurative language, such as raining cats and dogs, hot as fire? I had a college roommate who uses, I'm still friends with her, and she uses figurative language all the time, and we make a lot of fun of her because it's very country. She's from a small town in Tennessee, and she uses phrases like, "It's as tired as a tick on a dog in the middle of the country in July," or something like that. We don't even know what it really means sometimes. But anyway, so figurative language is that ability to understand humor, the ability to get metaphors and similes and idioms, and it develops over time. So middle school, high school age should really begin to use those abilities. And finally, we're looking at use, which is pragmatics, our intention. So using nonverbal behavior, eye contact, knowing the proper distance to stand away from someone when talking to them, appropriate turn-taking skills. Joint attention happens as early as 8 to 10 months, and that joint attention is when the parent and the child are looking at something while the parent is talking about it. So we know that that pragmatic skill is coming very early. If children are able to develop that. If they are not getting that skill, we might start to indicate might start to know that something's wrong. So the child and the parent are looking at an object together while the parent is talking about it. It's called joint attention. It's an important pragmatic skill developed early. Also, conversation and narration is part of pragmatics. It's how we use language, using it appropriately. Language is broken up into receptive language and expressive language. Receptive language is that understanding, comprehending any input. We know someone has strong receptive language skills when they can follow directions or when they indicate that they're understanding what we're saying. They're looking at the object we're talking about. They're following our conversation with head nods or answering questions about what we're talking about. Expressive language is the output, the speaking, producing language. Even signing can be expressive, gesturing, naming, writing, being able to ask questions. That's all expressive language. Receptive language and expressive language go together. Someone's understanding something, then they're able to express what they're understanding. Make sure that you understand the difference between language differences and language disorders. A language difference is not a disorder. It's determined by cultural factors or social or regional differences. These differences are observed in speakers who are learning English as a second language. So they're called ELL, or English language learners. So their English may not be as well spoken as someone who has English as a first language, but they don't have a disorder. They may have an accent or a dialect. They may speak a language. In order to assess people of other cultures, we make sure to assess language in their first language and in English to determine if there's a disorder. We always have to be careful that we're not characterizing a difference as a disorder. We'll talk more about disorders and language differences in the multicultural section in Module 6. When children have a language disorder, there's going to be a breakdown in their form, content, or use, or in all of these areas. Speech-language pathologists must look carefully at each area in order to determine where the breakdown is. Is it the structure of their language? Is it what they're saying? Is it their memory, which would be content, semantics? Is it how they're using language? Those social skills. Can they maintain eye contact? Can they take turns in conversation? Do they know the appropriateness of certain words in certain situations? So just as with speech sound disorders, in order to determine if there's an impairment with the child's language, we must do an evaluation. So the evaluation process is very similar as with a child who has a speech sound disorder. We must conduct a case history where the parent indicates any previous problems, medical history, birth history, environmental situations, school, family, social, and any important information that may affect the child's language. An interview should be conducted where the speech-language pathologist asks questions regarding the child's language development. What were their first words? When were their first words? What does the parent perceive as the problem? Maybe find out what the teacher perceives as a problem. Has anyone else noticed any problems? Does the child show frustration? And during the interview, you ask a lot of open-ended questions to try to get a general understanding of what's happening with the child's language. So after you have the case history and the interview, you know where you're going to start. And usually you're going to start with a hearing screening. You're going to make sure that there's no hearing problems, and if the hearing screening has failed, you might refer for a hearing evaluation. You also want to conduct an oral facial exam just to rule out any structural problems. You always want to do a hearing and oral facial just to make sure that there's nothing structural that's going to affect language development. And then you want to do a formal analysis of language. You do that by conducting a language sample, and that's where you video record or audio record the child's spontaneous speech in play, and you calculate mean length of utterance. So that's MLU. We're looking at number of morphemes that they're producing. That tells us in those 14 morphemes, if they're developing normally, they have the morphemes they should have at at whatever age they are. And then we look at the number of different words. So those semantic skills, or are they using many different words and different types of words and requesting and labeling? Are they asking for more? Are they rejecting and using negation? And then we'll probably give a standardized assessment. We almost always give one or more standardized assessment. And there's many different standardized assessments out there. One popular one that we give a lot is called the SELF. There's also the SELF Preschool. The SELF stands for the Clinical Evaluation of Language Fundamentals. There's also the OWLS, which is Oral Written Language Scale. There's the TOLD-P, which is the Test of Language Development Primary. There's the CASEL, the Expressive Vocabulary Test, the Test of Pragmatic Language, the Preschool Language Scale. There are just countless standardized language assessments. So once you've given your standardized test, you've calculated MLU and DW, you've looked at the language sample, you may have given some informal assessment by asking the teacher questions, or you may have done some other observation with the child. Then you begin to analyze the data and you interpret the data. And you start to figure out if the child is developing normally or is there an impairment. And where is the impairment? Is it in form? Is it in content? Is it in use? Or is it in all three areas? Then you write an evaluation report. And there's an example of an evaluation report on page 105 in your book, and also one uploaded into this module, so you can look through that sample report as well. The report should always include background information and then each section that you conducted an assessment. And always we put prognosis, recommendations, and any goals that we might begin to work on in therapy. This evaluation report gives us a baseline of where we're going to begin in treatment. When talking about language impaired populations, we need to remember that language impairment may be the child's only disorder, or it could coexist with other impairments such as articulation disorders, intellectual impairments, even language differences. Also structural problems. It can coexist with cleft palate or hearing impairment. In this section, we will talk about different populations who are affected by language impairment. When you speak of these populations, you should always use a person-first language. So you would say a child who is a late talker, or a child with autism spectrum disorder, a child with expressive language delay. You put the child or the person first. It's respectful and professional. So the first population we'll talk about are children who have expressive language delay or early language delay. The book classifies these children as late talkers, or children who are late talkers. These children are usually identified around their second birthday because the parents begin to notice that their peers are speaking at a much faster rate than they are. They're developing language at a much faster rate. They're using more words or putting words together. They're noticing that their child doesn't have as many words as a peer does. So these children who are late talkers or have expressive language delay typically have small vocabularies. They've failed to develop some of these semantic relationships and putting these words together. Some of their important developmental milestones may not have been met. Sometimes they have small phonemic inventory, so they don't have as many sounds in their words. And then there can be a delay in acquiring the morphemes too. So they may not put the S on the end of words or the ED or some of those early developing morphemes. They're also found to have small verb vocabularies. So they're not using a lot of action words. Verb vocabulary is very important in learning tense and agreement of morphemes. One important skill to notice children is gesturing. Gesturing can be a good indicator of if expressive vocabulary is developing. Because remember, gesture shows intention. So we know that gesturing is a precursor to expressive vocabulary development. So that's why speech language pathologists will often use sign language when a child has early language delay, because we're teaching them words with their hands, and then eventually those words with their hands become verbalizations. We know that gesture leads to verbal output. Another good indicator that expressive language may be developing are strong receptive language skills and strong play skills. Those can be good predictors of whether a child who is a late talker will outgrow his early language delay. So it's important to notice play skills, gesturing skills, and receptive language skills, as they all are good indicators of whether a child is just a late bloomer and they're eventually going to catch up, or if they might have further language impairment that'll persist. Some speech language pathologists, depending on these indicators, will decide if a child needs therapy or if they need to wait and see if the child will catch up. So some speech language pathologists will decide to wait and see, because these children are showing strong play skills, strong gesturing skills, they have strong receptive language, they may have good peer interaction, and they can see that the child is catching up or will catch up. And then other speech language pathologists will decide to put a child in for early intervention and deem therapy as necessary to help the child acquire these important language skills. So as you become more trained in language development, you will be able to make these important decisions on whether a child is catching up or will catch up, or if a child needs intervention. Some of these children who have language delay that are not just late bloomers and the language problems do persist will eventually be diagnosed with something called specific language impairment. And these children are classified around age 4, because there's such a large population of late talkers that outgrow their language delay. We don't want to over identify SLI. We don't want to say a child has specific language impairment when they don't. So this is not usually diagnosed until age 4, when after children should have grown out of that language delay or expressive language delay. So if this language problem is persisting, then a child may be diagnosed with this. So let's talk about the population of children who have specific language impairment. This language impairment is usually identified when there is no other problem. So they don't have a cognitive problem, a hearing problem, autism is not present, there's not an intellectual disability or sensory, social, emotional impairment, there's no environmental deprivation. So it's strictly language. Morphology development and semantic development tend to be greatly impaired with children who have SLI. So children have trouble with verb tenses. They have trouble putting words together to make sentences. They have trouble with grammar. And then they also have trouble with vocabulary, with remembering words. They may need more than one exposure to certain words to learn those vocabulary words. They need they have some memory. They might have some memory problems. So SLI can affect one or more components of language. It can affect just semantics, or it can affect semantics and syntax. It can affect semantics, syntax, and morphology. These children tend to look like children who are younger than them, children whose language is developing normal but younger. So they tend to have structure and development of someone who is much younger than them. Research has shown that there's a genetic component for SLI. Maybe their sibling or parent also has language impairment. Also, these children may demonstrate other neurological weaknesses such as clumsiness or poor motor skills, such as handwriting, delays, etc. Pragmatics may or may not be affected. Those social skills could be impacted, but sometimes they're not. Sometimes these children are fine pragmatically, but other times they're less socially interactive. And then phonological impairment may or may not be present. So sometimes they may have SLI without any phonological problems. The next population we'll talk about are children who have autism spectrum disorders. These are a complex set of pervasive developmental disorders, and they include autism, Rett syndrome, childhood disintegrative disorder, Asperger's syndrome, and pervasive developmental disorder not otherwise specified. So PDD and OS. You've probably heard of some of these disorders, but they're all grouped together under ASD, or autism spectrum disorder. So we look at these disorders along a spectrum from less severe all the way up to very severe. So autism is considered the most severely disordered of all these impairments, and then PDD is considered the one that is least impaired. Autism spectrum disorders are characterized by impairments in verbal and nonverbal communication. Social interaction is greatly impaired. There's usually some restricted, repetitive, or stereotypical patterns of behavior and interests that take place. Some of these impairments include poor eye contact, lack of play skills or pretend play, lack of gesture and ability to use expressive verbal communication. Sometimes there's a language regression. So a lot of times we see that parents report children were developing. Typically they had words, and then all of a sudden they lost those words, and then they just stopped gaining any new vocabulary. They may be repetitively engaging in meaningless activities such as twirling their hair or spinning the wheel on a car or lining things up. Research has shown that these children, just like with SLI, these children with ASD show some neuroanatomical differences from the general population. So we do see some brain differences in these categories. So children with SLI, they've looked at their brains and they see that there's a component that a little bit different than typical population. And the same with autism spectrum disorders. We see that there's a component of their development that's the same in their neuroanatomy. And there also appears to be a genetic link for autism spectrum disorders, just like with SLI. There tends to be a genetic link. Rett syndrome and childhood disintegrative disorder are rare autism spectrum disorders. And Rett syndrome usually occurs in females. Children with Rett syndrome usually have intellectual disabilities and often have a repetitive hand washing movements, like rubbing their hands together. Children with autism and Asperger's syndrome have poor social and emotional responses to others. They have trouble developing peer relationships. They don't spontaneously engage. The prognosis for individuals with Asperger's is better than for individuals with autism. Individuals with Asperger's can live and work independently, and their social impairments are part of their personalities. And sometimes these people are considered to be eccentric or just odd. But then people with or children with autism or individuals with autism tend to be more dependent on their family or need more support and help, even on into adulthood. So intellectual disability can co-occur with ASD. You usually don't see it with Asperger's syndrome, but you can see it with the other ASDs. PDD-NOS, the one that I mentioned that was probably the least severe, is a category used for children who demonstrate impairments in the areas of social interaction and other behavior, but they don't meet all the criteria of the 4 diagnoses. So sometimes a doctor, a developmental pediatrician, or a psychologist will diagnose a child with PDD-NOS when they're younger because they're not sure if they have all the components of autism or all of the components of Asperger's. So, for example, my cousin, who is now 13, when he was 3 and first diagnosed, he was diagnosed with PDD-NOS. The doctor almost was afraid to give him autism, wanted to wait, even though my cousin, his mother, says that she knew then that it was autism. So when he was about 5 or 6, they gave him the autism diagnosis because he did start to show all the characteristics of autism spectrum disorder. And now that he's 13, he's still exhibiting those characteristics, even though he's verbal. Some can use some verbalizations, though it's very rote, and he has some idiosyncratic movements that he uses and touches things and has sensory issues. Many children with autism spectrum disorder are nonverbal. And the research shows that if they haven't achieved functional verbal communication by 5 or 6, the prognosis is poor for developing those verbal skills. So it's important to intervene early. The primary impairment for autism spectrum disorders is pragmatics. That's those social skills. And one of the earliest indicators is that joint attention. So if we notice that children are not developing that skill of joint attention when the parent and the child are looking at an object and the parent is talking about the object, we can start to note that there might be a serious problem with pragmatics. So we need to keep that in mind when we're looking at young children. Echolalia and prosody are 2 characteristics that are often used with children who have autism spectrum disorders. Echolalia is that immediate or delayed repetition of language. So it's parrot-like speech. If I say, "What is your name?" and the child will say back, "What is your name?" Sometimes it sounds very robotic-like. So there's a lack of prosody or intonation in their voice. Some researchers suggest monitoring echolalia. It may be a good indicator of comprehension, or the children actually comprehending what is being said. If they're using echolalia, oftentimes that's indicating that they're not comprehending what is said, they're just repeating it. But then as that echolalia decreases, we might see that they are understanding more because they're not using the echolalia as much. The next population that we'll discuss are children who have Down syndrome. Down syndrome is a genetic disorder and usually accompanied by intellectual disability. There are three types of Down syndrome: trisomy 21, translocation, and mosaicism, and all of those have to do with a chromosomal mutation. Most children with Down syndrome have the trisomy 21, which is an extra copy of the 21st chromosome. So there are some clinical features of Down syndrome, such as flaccid muscle tone, flat facial profile, some facial differences, short stature, mental retardation or intellectual disability, and congenital heart disease. All are characteristics of Down syndrome. Language development for children with Down syndrome follows a typical sequence of development, but is largely in line with their cognitive ability. So there's only so much they can learn because of their intellectual disability. Some researchers found that an early difficulty in nonverbal communication indicates that they'll have poor language later. They are able to understand a great deal of words, and they can use gesture to communicate. And there's usually a richness in the information that they express. Certain biological factors and environmental factors impact who is at risk for language impairment. These biological factors include prematurity. If a baby is born premature, they can often be at risk for language impairment because they're going to be developing at a different rate, or maybe developing some milestones at a different rate. An intraventricular hemorrhage or a stroke can occur in premature infants, either in utero or even out of utero, that can affect language impairment. Ear infections can greatly impact language development. If children are having intermittent ear infections throughout development, this can impact their ability to acquire sound and language development. Low birth weight is a factor. Children are not healthy. They're not able to acquire certain skills. If they've been exposed to drugs and alcohol in utero, that can impact language development. Some environmental factors, such as neglect and abuse, impact language development. For example, if children have not spoken to or have not been cared for adequately, their language can be delayed. Socioeconomic status or poverty can impact language development. They may not be getting enough sleep, adequate nutrition. Their lifestyle may not be adequate. They may just be sitting in front of the TV, or they may not have access to books. This can impact language. A child who's a product of multiple births, whether twins or triplets, can be a factor. Sometimes their language can be delayed. Maybe attention is being divided among 3 or 4 or 5 infants. Therefore, the language development could be delayed in a child. Now, remember, these are just factors. So a child could have some biological factors that impact language impairment. However, they have strong environmental factors that help overcome those biological factors, or vice versa. They could have some environmental factors, but then they have some strong biological factors that help them overcome the environmental factors. So these are just indicators that show that children might be at risk. It doesn't mean that they necessarily will be. Of course, if they have one factor, they're going to be less at risk than if they have 4 or 5 factors. So these are things to take into consideration when you're evaluating a child. So when do we know that it's time to intervene? And what do we do to intervene with children who have language impairments? Well, after we've completed the evaluation, we have a good idea of where the language breakdown occurs. So then we begin to develop goals. And during the evaluation, we've done maybe some trial treatment to help us determine what types of interventions that we can use. One thing we want to start with, capitalize on the strengths of the student or the child. If they're using gestures, we want to build on that. If they're using one-word utterances, we want to build on those. If they have strong receptive language skills, we want to use those to teach expressive skills. And then we want to minimize the weaknesses. If they are not asking questions, we want to try to teach them how to ask questions. We want to look at the skills that come before asking questions and make sure they have those skills first. And then we also want to use strategies. A strategy is a plan of action that helps children learn or helps them achieve an outcome. So for example, like an older student may need you to highlight certain words in their text. You may have to teach them to look for specific words to know that those words are indicating a question or indicating a statement. The speech language pathologist can teach new language skills by using something called scaffolding. Scaffolding is a support that makes an aspect of a task more explicit. So for example, you can model something, or you can use a visual prompt or a verbal prompt. So you're doing more for the child so that they can grasp the skill. Then as the child gains the skill, you can reduce the scaffold. So for example, if you're using modeling, visual prompts, and verbal prompts to teach a child how to write a sentence, and the child begins to get it more independently, then you can slowly take away the visual cues and then take away the modeling, and then eventually all you have is maybe just a one-word verbal prompt that's helping the child write the sentence. And then eventually you can take that away where they have no prompts and they can write the sentence on their own. Then if you find that they're still struggling, you may need to add back in the verbal prompts. You may have to add back in the visual prompts and then take them away again. Scaffolding is used with speech sound disorders as well. So for example, if you're modeling the way a child needs to say a word, or you're giving them a verbal prompt of how to say a word, and then you can scaffold, take away the model and just give the verbal prompt. Or you might give a tactile prompt by pointing to the lips or where in the mouth the sound should be produced. So scaffolding is a very popular technique, support that speech language pathologists use. Also, modifying environmental factors might be very important when intervening in language development. So for example, we might encourage the parent to involve the child into a peer group or a social skills group, or encourage the parent to enroll the child in school if they're not already in school. We may encourage some sensory interventions at home to reduce stress or anything that's causing problems with language development. All of these things that I've just mentioned can be used in intervention for children with language disorders.